Namrata, Rajesh.
Yes, Mohan, we are just starting. So it is a pleasure again to have this Surginar after many days. And we have with us Dr. Mohan Rajan, who is the chairman and medical director of Rajan Eye Care Hospital Private Limited from Chennai, and Dr. Sujata Mohan, who is the associate medical director from Rajan Eye Care Hospital Private Limited, Chennai. And we are going to be showing you live telecast of interesting cases from the operation theatre from Rajan Eye Care Hospital from Chennai. I have with me my co-moderator, Professor Rajesh Sinha, who is the treasurer of the All India Ophthalmological Society and professor of ophthalmology at Cornea, Cataract and Refractive Surgery Services at RP Center, AIIMS, New Delhi. And we also have Dr. Lalit Verma, the president, and Dr. Harbanslal, the president-elect, who would be joining in very soon from the All India Ophthalmological Society. I would request Dr. Rajesh Sinha to introduce Dr. Mohan Rajan.
Good afternoon, everyone. It's my great pleasure to introduce Dr. Mohan Rajan, who is the chairman and medical director of Rajan Eye Care Hospital, which is a super specialty and postgraduate institute of ophthalmology affiliated to National Board of Examinations. He is specialist in both anterior and posterior segment surgeries and has made more than 2,000 presentations, national and international, and has performed more than 130 live surgeries across the world. Has several innovations to his credit, like Panchorexis, Mohan Rajan Chopper, etc. Has delivered 27 named orations and published 46 publications in various journals. He has won several Best Video Awards from AO, APA, RS, ASCRS, ESCRS, APAO, WOC, etc. Has received Best Doctor Award twice from Government of Tamil Nadu. Has trained and mentored more than 600 ophthalmologists around the globe. He is also the winner of 58 Ophthalmic Premier League till date. That's a world record. He has many such records, and I had privilege of doing live surgeries with him and at various occasions. On various occasions. So with great pleasure, I would like to have Dr. Mohan Rajan with us. We'll be shortly doing the live surgery.
Okay, Rajesh and Namrata.
Mohan, let me also introduce Dr. Sujata Mohan, who is a dear friend of mine, who's Director Rotary Rajan Eye Bank, Associate Medical Director Rajan Eye Care Hospital, has performed more than 50,000 refractive surgeries, 80,000 IOL implants, more than 2,000 corneal transplant surgery, has presented more than 150 papers in national and international conferences, has more than 25 publications to her credit, conducted over 100 CME programs, 500 eye camps, and was adjudged as one of the top women ophthalmologists in the country in the year 2009 by a survey in Ophthalmology World Report. She was awarded the T. Agarwal Gold Medal for Best Woman Refractive Surgeon by Srimati Sheila Dikshit, Chief Minister of New Delhi in 2010, and was awarded Best Video and Refractive Surgery category in APCARS in 2012. She also has received G. Sita Lakshmi Gift of Sight Award from Lions Club of International on Helen Keller Remembrance Day 2017, and was also awarded by Dr. Nataraja Pillai the Best Paper Award at Shankar Netralaya Alumni Meet, July 2018. So over to you, Mohan, now for your live surgeries.
Able to hear me, Namrata and Rajesh?
Yes. Clear, okay. Very clear.
It's loud and clear. Okay.
Absolutely loud and clear.
Let me thank AOS as well as J&J for this Surginar. I think this is the 5th time this Surginar has been fixed. Namrata knows very well about it, and at last we got it. Thank you very much, Namrata, for all your efforts, and also the J&J. The first case, I'm going to demonstrate a femto in a intumescent cataract. Okay, it's a well-dilated pupil. It's about 60-year-old female, about grade 3 cataract, very intumescent. And I'm going to try, definitely the rexus will be possible, whether it's going to cut the cataract or no, depending on whatever the OCT recognizes, then we'll know. I'm going to, you're able to see the liquid optic interface here. I kept the liquid optic interface here. Section on. You able to see that?
We were not able to see that. I think they have to show through the external camera, please.
External camera, can you just focus? The external camera.
Yes.
Yeah,
Now we can see.
Maybe yeah.
Now we can see. Very good. Excellent. Excellent.
You able to see that?
Yeah.
Now I am
Yes, we can see.
going to log this liquid optic interface into the system. So I'm operating on the joystick here clockwise, and it gets locked into the system. And this is a Z height. Then I center it. Then I capture it and lock the system. Wait, don't shout. Yeah. You're able to see the screen here now?
Yes.
The screen, you can see that the OCT is recognizing the different parameters in the eye. The central corneal thickness, the aqueous depth, the anterior chamber depth, the lens meridian position, the lens thickness, the pupillary diameter, the white to white. So you can see the white to white is about 10.4, pupillary diameter is about 7.5, lens thickness is quite a thick lens, 4.6 millimeter, and is able to recognize the, yeah, I'm going to increase the offset because it's not recognizing the posterior aspect. Yeah. You can see the vacuoles underneath the anterior capsule. So the offset is normally about 500. I kept it around 900 now. You able to recognize? Yes, you able to recognize. Yes. And being a 6.0 software, I'm putting the axis of the intended cylindrical, that is the intended axis on the cornea as well. It marks the toric axis as well. So there is a synergy toric which you are planning to do. So it's about 28.8 seconds with the center on. It skips the center, and you can see the capsule may take. I'm going to start the femto now. The axis is over. It's fragmenting the lens now. So despite the fact it's a very hypermature cataract, the laser is able to penetrate. So it's a versatile machine. The catalyst, it's one of the best machines, I would say. So if the fragmentation is over, now it's marking the toric axis on the cornea, which is about 95 degrees in this case. And that's it. Here. Okay, here we go as far as the femto is concerned. Now, I'll wait for some time and Sujata will start the synergy toric manual. She will be doing that now. You can see that, and after that, I will take up this femto case. Okay. Any questions on this?
No, everything was very well explained. So there are no questions. We will go to Sujata's case.
Yeah, we'll do that.
Thank you so much, Dr. Mohan.
Can you shift the transmission from the other or?
On the microscope.
Yeah,
microscope.
Yeah.
We can see you, Sujata.
Yeah, we can, I want the microscope camera to be switched on.
Yeah.
Microscope to be switched on, please.
Yeah, thank you.
Yeah.
So this is a toric, also a synergy toric. And I just want to mark that though we have a Callisto, you can see the 0, 180 degrees, 30 degrees is going to be by Mancition. And where is, and it's at 150 degrees. So just putting the marks. And now we are starting. I'm going to do it in the topical anesthesia. Hopefully the patient cooperates. Nere parunga sir. In the mela duspanna. David. Oh. Okay. Just a little bit. Table up. Okay. Side put. Callisto off pannilam. So தொடர்ந்து தெரியும் வலி இருக்காது அசைக்காதீங்க. put a side port. I'm putting Bluedex. So I'm going to use Trypan Blue because the cataract is quite hard and the red reflex may not be very good in this case. So Oculan put it, yeah. Oculan powder.
Sir.
You're okay, sir. Just relax, okay? Everything is going on well.
So this is 2.2?
2. No. This is
2.8.
2.8.
2.8. Okay.
Yeah.
2.2.
We use 2.2 or 2.8. In this case, we used.
Yeah. Okay.
That's the advantage of using a signature pro. You can go either way.
2. No.
This is 2.8.
2.8.
Don't hit against my chair. Someone is sitting.
You saw that she's doing a rexus with the needle.
Yeah.
Yes. And her rexus is as good as
Very
the rexus.
Many times it's better than my Funto rexus as well. Yes.
Yeah, it's wonderful. Very good.
The machine which you are using is a Signature Pro machine. As you know, the advantage of the Signature Pro machine, we'll talk about it during the surgery.
Yeah.
He's doing a gentle hydrodissection, making sure that every time you decompress the nucleus back into the bag.
Yes, you're on, Panna. Elimination max, please. Start to put. So what I'm doing is I always try to do a small central trench, but today I'm making a little bit larger because the cataract is quite dense.
Yeah. And
Okay,
a very good cataract to use
Mohan
Rajan's chopper, no?
Yeah, she using this Mohan Rajan chopper only 1.75.
Yeah.
And yeah.
Hold on.
Her vacuum, she's using around 500 now. Yeah.
It's not holding.
Yeah.
Now I got it. Still not holding.
It's important that in the vertical chop, you need a good hold.
Yes.
Pulse random.
Yes, continuous.
No, continuous phaco. Okay. Now
See that? You can see how the chopper is working.
Yes.
Once you hold it, it's very easy. It works, opens up the posterior nuclear plate without any problem.
I wanted to say, Mohan, how well Sujata is working and chopping.
Absolutely.
Help of your chopper.
No doubt about it.
But very elegantly done, Sujata.
Very elegant.
Wonderful. I think, Mohan, I'm going to buy this chopper now.
I'll send it to you.
Yeah. It is 1.5 millimeter, right?
1.5, 1.75, and 2. 2 is for black cataracts.
Who makes it? Who makes
Apasami.
it?
Okay.
1.5 is for grade 2, you can use it. And grade 3, 4, you can use 1.75, grade 3, 4, 5. So she's using the hyperpulse, which is part of the cold phaco, which is a white star. The advantage of the Signature Pro is that the stability is Really fantastic, despite the fact that you're using high aspiration flow rates and vacuum as well. It's got an automatic occlusion sensing. The IOP change is 12% more than the IOP change is much better than the Centurion as well, which has got active fluidics. See the fallibility and the stability of the lens of the anterior chamber as well.
Yeah.
The advantage of this is that it's a dual pump. So the fluidics is on demand here. By a switch of a button, you can go from the venturi to the peristaltic. So till this time, you can use peristaltic. Normally we use. Sometimes during the cortical removal and epinucleus removal, we use a venturi as well. Absolutely, there's no problem at all.
Very nicely emulsified.
Ah.
Since it's
superb, Sujata.
And she did something like a cortical cleaving hydrodissection. There's not much of the cortex also there.
Yeah.
And the epinucleus has also come along with the nucleus. She's going to put the synergy toric lens. As you know, synergy toric is a new addition. We all are familiar with the synergy lenses. It's a continuous range of vision lens. It's a combination of symphony and thickness multifocal. It gives vision at all distances, starting from 35, 60 centimeters, 80 centimeters, 120 centimeters, infinity. And that is the beauty of this lens. And they have the addition of a toric now, which is now increase our indications or expand our indications as far as the premium lenses are concerned.
So when you select the IOL power, what is your target refraction? Like
synergy, we always make it a little hyperopic.
Mm-hmm.
We go for the next lower plus power.
Mm-hmm.
Yeah. Suppose it's 21.5. Depending on the IOL Master 700, we use the IOL Master 700 here. And we use the Barrett formula. And all the formulas, all the this thing, we feed it in the Barrett toric calculator. And that's the reason why even our regular ones also, the Barrett toric calculator will tell you whether you need this patient requires a toric lens or a regular lens.
This is a screw type injector, right?
This is a platinum injector, which is a beautiful injector. It goes through a 2.2. And you can see the lens is beautifully there. Though it's a ring lens, surprisingly, the glare and halos are very, very minimal for these patients.
Flush.
So have you compared it with the current trifocals that in terms of the photic phenomenon, in terms of glare and halos?
Yeah. We have done a study.
So this is better in terms of lesser halos, lesser glare.
No, my personal preference is if I want the patient wants to read, look at the computer and do everything, synergy will be the first choice.
Okay.
And the patient wants to read a lot. And that's the main purpose, then I would go for panoptics lenses, because the reading is for a longer time, it's much better with those lenses.
Definitely. See, the patient nowadays, the more than the reading, the intermediate is more important. I call it the new middle.
You want
Okay.
Callisto. Callisto,
Yeah.
please.
Callisto is on. Callisto, okay.
Yeah. Now you can see the Vela. It's aligned. I've just made the dots just in case you lose the Callisto.
We can't see that line.
Yeah. Just
Wait. 1 minute.
now can you see?
Able to see that blue line? It's only on this screen you can see.
So the blue line we can't see. If you
We
can
can't see.
Blue line on the, get the external camera on the monitor, please.
Panel can
Yeah.
capture.
Yeah.
Okay, it's well positioned now.
Here, by this monitor, this monitor.
No, this monitor we can't see. It has to be the monitor of the.
1 minute. See the blue line.
Yes.
Blue line.
Yes.
So you have to make sure that it is there in the center.
Yeah.
The blue line is quite fine.
Absolutely.
The markerless system, which is
Yeah.
Callisto. This is compatible only with the IOL Master and the the Lumira 700 microscope.
True.
Yeah.
So, very well said.
It's hydrating the ports very nicely, making sure it is not very deep. Same time, it is not very shallow also. Very deep, sometimes it will rotate. Normally, we keep the patient for a few hours post-operatively and check the axis correctly.
So, sir, 1 minute, 1 nimsham.
So before
receive intracameral moxifloxacin.
Mohan, before sending the patient, do you again check on the slit lamp?
Yeah, we check it. We check on the slit lamp after a couple of hours, and then we decide.
So, Mohan, there are several others who use your chopper, and on the YouTube and the Facebook, they have posted that they are using your chopper and they are very happy with it.
Yeah.
Drops.
Yeah.
Thank you, Namrita.
Perfect. That was absolutely.
Thank you. That was. Yeah.
We're going to have one more surgery by Sujata.
Yeah.
That is the high hands after my case. The femto case which I did, I'm going to show that now. That's also a synergistic. Just give us 2 minutes time.
Surely, Mohan.
We'll discuss about the case. See, the
table height coming. Switch off.
Regarding the, are you able to hear me?
Switched off.
Yes, Mohan, we are able to hear you very clearly. Hello, Mohan?
We can't hear you now.
We can't hear you, Mohan. Sami, can you coordinate?
Yes, ma'am.
Sure, I put the mic.
You can hear now. So, Mohan, we can't hear you. I think.
Yeah, 1 minute. Just give me a minute, Namrata.
Can hear you now.
Get the patient ready.
Sudhakar, you ship the patient now.
Table up. Okay, generally what we have seen is that table up.
You don't go. He's standing.
Okay. Generally, the trifocals, the Lisa or the synergy, though the synergy they don't say is a trifocal, they say it. The J&J says it has a CRV lens. Actually, it's a trifocal lens. Table up. Yes. Because it's a combination of the EDOF and the multifocal. Table up a little. Yeah. Generally, the glare and the photic phenomena are much less with this.
eyepiece மேல தூக்கு -3 பண்ணு.
3 sir.
PB பண்ணுமா. நேரா பாருங்கம்மா. அப்படியே இருங்கம்மா. Blurex and T+.
So this was the intermittent cataract on which already
Yes,
femto-
yes. Because we waited for some time, the pupil has become a little small. Can you see that?
Do you use any NSAID? Have you tried
Yeah, we do that. We do use
these
that.
cases? Sometimes it helps in preventing
நேரா லைட் பாருங்கம்மா.
the pupil to become small.
Okay, you can see the callisto is there. So I'm going to mark the, I'm going to put the side port first. And I'm going to put Blurex, T+. Blurex. Ma, aseyadingamma konjam.
So Blurex, if you put on the incisions also, it tells you, you know, where the incisions are,
Yeah.
especially in a Rajesh, what is it?
No, but once you do femto incisions, then it helps.
Yeah.
It stains the outer
Femto
limb.
incisions, I've used to do that. Nowadays, we are not doing the femto incisions much. So I don't want, I mean, we do it in the younger patients, we do it when there is no arcus or anything like that.
Yes.
So we wait for some time. The reason why I'm putting Blurex is that, please understand, the femto in a mature cataract is totally, the rhexis in the mature cataract, the femtorhexis is totally different from a rhexis in an immature cataract. Okay, that will be free floating. Here there can be skip areas, so you have to look out for that. If you don't try to pull the rhexis, look out for the skip areas. As you can see here, there are still some attachments there.
Yeah.
You able to see that?
Yeah,
Yes.
you can see
It's
that.
very important for you to understand this ball game. Callisto off panni. So what I do is I just put some dispersive viscoelastic there, and also make sure that you can see here what I'm
What forceps are you using, Mohan?
just regular micro Uttata forceps. See this? See this?
Yeah.
Don't try to pull it out, okay? In a mature, see this? Slowly I'm doing it, okay?
Yes.
If you try to pull it out, there can be attachments that can give way. I hope you got the point.
Yes, yes.
Very gentle hydro, because
Leads
already
to
some,
extension also, peripheral extension.
yes, you can have all these problems can occur. That's Blurex. Okay, anyway, sponge the middle canthus, please.
So what percentage of your practice is femto, Mohan?
I'm doing almost 40% now.
Okay.
So I'm just removing the superficial cortex and epinucleus, and you can see some, that is what I'm trying to say. You can see some cuts on the capsule and on the nucleus as well. Can you see that?
Yes.
Yeah.
When I make the chop, probably you'll know that better. See this? Already it's cut. Can you see that?
Yes.
I'm just opening that area.
And it is very useful and helpful that, you know, the pre-cuts are already made.
Yes. Now you'll be able to, it's very, very well delineated. So I have cut into two halves, and then I'm attacking each of these halves. in the area which is already pre-cut area. I'm going there because already it's pre-cut, pre-chopped for me. And then the parameters I'm using is very high vacuum and flow rate as well. Please sponge ma middle canvas, please.
It is shallow, but still it is, very stable.
This is a hyperopic eye. Raju, sponge middle canvas. You can see the half the nucleus has come now. I'm switching over to the coaxial on the microscope. Can you see that better now?
Yeah, it's better.
Very well.
The beauty of this machine is that you just have to stay in the center and see the fallability. It just comes like
Fallability
that.
is very good.
Really fantastic.
Yeah.
25. So the surge, everything is very, very less, almost minimal because of the automatic occlusion sensing, which is a feature of this wonderful machine, I would say. And these are actually the signature, the J&J, they are the gold standard as far as the cold phaco is concerned. They were the first ones to introduce the White Star phaco, and which is the White Star software, which is a part of the cold phaco, which is a hyper pulse. Subsequently, all other machines copied, and even the Ozil is also a copy of that only. It's a part of that only. Though it's oscillatory movement, the ellipse is there in this, wherein it's not only longitudinal, it's also transverse, everything is there. The advantage is that the followability of the pieces. Cortical removal is a little tricky in femto because there's no edge there, because it cuts through. CP board. Put something on the cornea, please. Yeah. Max. I'm just trying to remove the epithelial cells on the posterior capsule periphery, not in the center. The center near in the equatorial area.
So your
Hope you're able to see.
bent IA is helpful in
Yeah.
in sub-incisional.
Coaxial.
Yeah.
I always use only coaxial bent. There is a curved one.
Yeah.
See, you can see the axis of the location is already marked here. Can you see that on the cornea?
Yes.
See, this is a 95 degree, which I marked during the femto.
Yeah.
When I did the femto, this is a 95 degree. But if you see the callisto, it is also coinciding with that. Can you have the callisto screen, please? Our Tamil Hindiya. Kamal, okay, just show that screen.
Yes, we can see that.
Yeah.
You're able to see the blue line?
Yes, yes.
The blue line and the 95-degree, which I have done with the femto incision on the cornea are coinciding. So I have two ways of checking this. You got the point?
Yeah, this is wonderful.
Yes, that is the advantage of doing a femto.
Yeah.
All my torics, if it's about one, I do even a lot of astigmatic keratotomy as well. If it's about one cylinder, more than one cylinder, I go for toric. The synergy toric, I would say, we have been using it for the past now almost a month now. The stability, rotational stability is really fantastic, this synergy. I would say the synergy is one of the best platforms. So it's important that you remove the viscoelastic from behind the lens and then rotate the nucleus. I'm sorry, rotate the lens.
I will.
I will.
Okay, spend enough time behind the lens there. Make sure that you remove a good amount of viscoelastic there. Then try to rotate the lens always clockwise. Okay, you can see the Purkinje images right in the center ring. Try to center that Purkinje images. That is the third and fourth Purkinje images.
Yes.
And then, wait, we have time, man. We have time till 5 o'clock. Don't worry.
Yeah, we have enough time. Don't worry, please.
Yeah. Sujata is in a hurry. I don't know why. We have time. We have got only one more case.
Yeah.
Yeah, see, can see that it's coinciding very nicely?
Yes.
Yeah. You can see that.
This is the 95-degree which is made by the femto, and this is the callisto, and this is the lens. Everything is coinciding. And also you can see the Purkinje images right in the center ring, central zone there. The lens is well centered. I'm sure this patient will do very well. Light pargama. So hydrate the main port.
So every step very nicely demonstrated, Dr. Mohan. It was very nice. And most importantly, you explained everything very nicely.
Yeah, thank you very much. You can see that I'm just going to put some myocol there because the iris is coming out there. But otherwise, the patient is, I think everything went on well. This just to show you that even hypermature, you can get away with an Argentina flag sign, and it's a foolproof, almost foolproof, 100% foolproof, I would say. When you use a femto, I'm trying to use femto for all my cases with the mature cataract now. And also, many people say that the femto will not go through a mature cataract. As you saw that the femto, don't underestimate this, is a very versatile machine, the catalyst. So once the OCT recognizes, it can cut the nucleus as well.
Yes, even in a white cataract, it was able to penetrate.
Yeah, it was able to do that very nicely. Just enough tighten. I don't tighten it too much. But if you tighten it too much, there's a possibility of rotation, especially in high myopes. Of course, this patient is hyperopia. It's about 26 diopter. So don't tighten it too much, but make sure it is not very loose also, because if it's little less tight, the lens can move forward and rotate. Whenever you have doubt, this is a message I want to give everybody. If you feel that it's not anything, always put a suture. Nothing wrong in putting a suture. So I'm just checking here. That is at 6 o'clock. At 12 o'clock is where I'm sitting. 12 o'clock I'm checking. 6 o'clock I'm checking. Again, I'm a little fastidious about this. Hydrate the side port. Okay, ma. Nalla aachu, ma. Light therida, ma. Always ask the patient whether they're able to see the light. Okay, ma. So that's the end of the surgery. Synergy toric femto. Thank you.
Very nice.
Thank you. Thank you.
Next case is going to be by Sujata. She's going to do a manual with a high-ans lens. So I just want to show you this machine. Can you come this side, ma? This machine I'm going to show you. This is a Signature Pro. It's actually I would say it's a workhorse. I'm sure all of you are using this Signature Pro machine. And you can see this. The advantage of the Signature Pro is that it's got a user-friendly interface here. And you can see the aspiration. All the parameters are there. The vacuum. It's got a Venturi system. It's got a peristaltic system. By touch of a button, you can go from the Venturi to the peristaltic. You can see here, this is the fusion fluidics. You can see here, this is the peristaltic. And once you touch this, it go peristaltic. Once you touch this, go Venturi.
Somebody come in front of the screen. Yeah.
It's okay now?
Yeah.
Yeah. So the peristaltic, Venturi, the fusion, it's probably the only machine which has got both.
Yeah.
So you have the advantages of both. Actually, it's a peristaltic and the Venturi. So you know when to use Venturi, when to use peristaltic, and have the advantage of both. So if you want to have better epinucleus removal and cortical removal to be made easy, go for Venturi. Better holdability, also you can use Venturi. And followability, you can use Venturi or peristaltic, whichever is thing. But both of them work very well. Another big advantage is that you can go up till, see, I used almost 550, 600 vacuum in this case. And my aspiration flow rate was as high as 60. Okay. Which makes the entire surgery very fast. Okay. It has to be fast as well as safe, both ways. So both safety as well as the speed of the surgery, because you're able to increase the vacuum. You're able to work at very high aspiration flow rates as well. Now, Sujata is going to take over my mic. I don't require a mic at all. Namrata knows very well about it.
So, just want to say, Mohan, Dr. Shivaji Padamukhi, Dr. Subhasis Das, Dr. Vishnu Nadella, all of them are using your chopper and they are very appreciative about it.
Thank you. Thank you so much. Thank you so much. Yes. So the advantage of the Signature Pro machine, as you saw that it works for even the brown cataracts, black cataracts. It's really a workhorse. It's really a versatile machine. So that's what I tell everybody. Go for a machine which works in all types of degrees of cataract. Sometimes you have a machine which will not be very good for your very hard brown cataracts, or cataract rubra, or cataract nigra. But here is a machine which works in soft cataracts, medium cataracts, brown cataracts, red cataracts, black cataracts. So all across the entire spectrum, it works very well. And it's easy to maintain this machine as well. And of course, you don't have to talk about the backup service which has been given by J&J. Really fantastic they are. So this is a grade 2 cataract, and she's doing topical anesthesia and high-ans lens. We'll talk about the high-ans lens once it's implanted. But you saw that synergy toric lens is something which is a new addition in your armamentarium now, which works very well. And please understand that my toric implantation about 2-3 years or even 1 year back, I would say, my toric implantation. Yeah, we can start the case.
Sir, I'm starting the case, sir.
Yes.
So, small touch sensation.
Can we have the microscope view, please?
Yes, yes. Microscope view is on.
Yeah.
Huh? Plus one. 1 minute. We'll change it to plus. Changing the eyepiece to plus power. Sujata is a hyperope and I'm a myope.
Okay.
So I'm a negative, she is positive always.
Yeah.
So she's putting Oculon there and putting Hyalon. And then making the main port.
So I think Dr. Lalit Verma sir is also there. Sir?
Lalit, good afternoon.
He's watching us on the Zoom. Sir, can you join us?
Lalit?
Congratulating you, and he's on the YouTube, but I'm
Why?
sure he'll join very soon.
Yeah, very good. Anyway, we were talking about the incidence of toric implantation. About 1 year back, it was about 20%, but today it's about 45 to 50% for me. The reason why is that because now we have learned that all the calculators, all the formulas are all the calculations. We are now feeding it to the Barrett toric calculator. And the Barrett toric calculator will in turn decide whether this patient requires a toric lens or so. And the IOL Master 700 actually.
I'm doing the
Rexis. She's doing the Rexis now. Yeah, beautiful Rexis again. Very important for all patients to have a Rexis of about 5.25 because good overlap is necessary.
So nice.
Gentle hydro, no hydro delineation, only hydro dissection.
Good fluid wave, you can see this.
Nice fluid waves, she sees. You're able to see it's about grade 2 to 3 cataract.
Okay, now start.
Yeah. She's just making a small trench there. And again, she'll use my chopper. She has not paid a single paisa for me for the chopper.
Why should she pay you for the job?
She has not paid me dowry as well.
Okay, I'm doing the chopping now.
Excellent.
It's not holding.
No, it's continuous.
Continuous, Vijay. Okay, ready?
Yeah. That hold is necessary.
No, it's not holding. You know, it's 40.
She's using about 500, 550 vacuum here.
Not very good.
Yeah, it's okay.
Okay. I'm not very happy with the hold, but if you have a good hold, then you can chop even better. It's a little bit soft, but still, I think it's choppable cataract only.
Again, the chopping is vertical chopping. You need to go a little down into the body of the nucleus. Tilt the probe slightly down. Instead of being parallel to the rexus margin, see how she's going into the body of the nucleus, creating a nice vacuum seal and chopping right in front of the rexus margin.
Nothing is holding. Salena the corner, please.
Centering பண்ணு. Yeah. Rotate பண்ணி.
The nucleus is a little bit hard in the center, but still.
Yeah. Yeah.
Okay, got it.
See, what she's trying to do is to make sure that she chops and then brings it up. Don't, without chopping and making sure that you see the posterior capsule through and through, don't try to bring this nucleus up. Then you'll end up in a white cornea the next day. So make sure that you chop into smaller pieces. Retroma. And the beauty of this machine, you can see here, she just has to stay in the center there. Automatically, you don't have to chase the nucleus at all. Automatically, the nucleus comes towards the tip. And imagine she's using about 500 vacuum. Flow rate of about almost 55-60. The followability, the chamber stability is fantastic. The ellipse works very well. The amount of phaco energy with the ellipse is very, very less. Because it's cutting on both sides as well as in transverse movement, as well as in longitudinal movement as well. Yeah, correct. 25.
Okay.
So during the removal of the epinucleus, would you lower your parameters, Sujata?
Yeah, absolutely. I lower the parameters.
Yeah, we reduce the parameters a little.
Absolutely.
We bring it to about 25.
Okay.
25-30 flow rate and vacuum to about 300.
Yeah. The last piece itself I'll start reducing. So just make sure that there is, in spite of the fact most of these machines are very good phaco-dynamics and surge is very less. Still, it's the old habits die hard. We have been doing it for so long. So I prefer to do that. So it saves us a lot of headaches. Suppose something goes wrong with the machine. So
we have Dr. Lalit Verma, sir, who's joined.
Yeah, Lalit.
Yeah, hi, Mohan. Hi.
Hi.
The only thing I enjoyed in Sujata's surgery was that her, phaco probe was in the center and she did not have to go under the capsule to, bring the nucleus in the...
Yes.
That is the most enjoyable part.
Yeah.
What you were mentioning also, that you don't have to chase.
No need to chase. That's the advantage of this machine.
CP.
No, it was very nicely depicted by Sujata. Her probe was in the center always. Nice.
Lalit, it's a pleasure to see you every week.
Okay, so I've got a nice round rexus. Well, very well
nice.
centered.
Very nice.
I'm going to put this high-ans lens for this patient. As you know, this high-ans lens, we are either using high-ans on the unifocal segment or the multifocal, either the Synergy or the Panoptics or whatever it is, but mostly Synergy we are using. The high-ans, we market it as a unifocal plus lens. So what is the advantage of high-ans is that I make one eye, this being the first eye, we make it hemetropic. The other eye, it's no dominant or non-dominant. The first eye, we make it hemetropic. The other eye, we aim for about 0.5, maximum 0.75. We don't, 0.5 to 0.75 we aim. So that gives that something like a micro.
Yeah, basic aim is to, not spectral dependence at all for mobile and other things.
Yeah, micro monovision. And we tell the patient, because the high-ans works around maybe around 45 to 50 centimeters, they are doing very well. And many of the patients are using the iPad or the tablet or whatever it is, or the cell phone, only at 50 centimeters. No more the 35 centimeter rule is there. Nobody is reading newspapers now. They're all reading the newspapers on the phone, which is about 50 centimeters, 45 centimeters. In this case, the high-ans work very well. Occasional readers, many of these patients don't mind wearing. We tell them. But what is important is the contrast sensitivity is very good. No glare halos. The photic phenomenon is very less. The contrast, the quality of vision is very nice. They're able to drive at night, and they lead a very active life. And all my IONS patients are very happy. You can see again the hydration and the tightening of the chamber, very important. After tightening only, we put the intracameral moxifloxacin, because if it's loose, the moxifloxacin will come out. Lalit will know better than me. But if it's tight, it will be retained in the anterior chamber, which we want to.
Right, question, Sarita.
Yes.
So Rajesh, you also do the same, like one eye hemetropic,
Right, question, Sarita, sir.
having monofocal lenses. One eye
operation.
the patient first. But one eye hemetropic, other eye 0.5 or 0.75.
Sir, it depends on the demand of the patient. Patient is like that, can afford that much, and has a demand for spectacle independence, then yes, it's a good option that we can do a little action in one eye, so that the patient has a reasonably good vision for intermediate and then near. And the other eye,
Rajesh, every patient, you see, every patient will wish a spectacle independence. One patient who will say, "No, spectacle nahi chahiye." Everybody will want it. So is Rajan, is Mohan monofocal, monovision option?
yeah, this is a good option.
What we do is we
patients
especially high-ans lenses, we tell the patient, we do one eye, then when they come after a couple of days for the other eye, we'll tell them, ask them whether they want a little more near vision. We titrate the other eye, okay? And we make them about minus 0.5, a little. Don't make it 0.75 or 1, because sometimes 0.5 can come up to 0.75. Then you're okay. But 0.75 going up till 1.25, the patient will start comparing the distant vision. So I think you make it 0.5, and then invariably you are on the target. Maybe you're on 0.75 also, they are very happy, because the binocular vision is pretty good for distance and near vision. And please understand, the thing is, today's demand is not reading papers at 35 centimeters. It is reading an iPad or a tablet or a phone at 50 centimeters. So I call it the new middle, a new necessity, I would say. It's here. It's no more here. No more. It's a near point has actually receded from 35 centimeters to 50 centimeters. And that is where IONS works. Okay. And if they want continuous range of vision, then, and we tell them that photic phenomenon may be there, of course, with less, they don't want to have any risks about that. They're active night drivers. They're active in playing golf or something like that. And they're very active people. Then we ask them to go for IONS. Otherwise, we ask them to go for Synergy or Synergy Toric.
So, Mohan, are you a big fan of multifocal?
Yes, he is.
I'm a big fan of multifocal.
So, Mohan, I just want to bring to your attention that Professor J.S. Tityal also has been watching, and he's congratulating you for a wonderful surgery with great teaching tips. And he wants to know which machine was being used for the first case and the second case both.
Yeah, but all the cases only Signature Pro machine. Being a J&J event, we can't use any of the machine. Okay. There's a Signature Pro machine which we are using regularly in our OT. And the advantage is that we use the peristaltic only for this. Sometimes we use the Venturi mode also, the dual pump, as you know. And the stability of the chamber, everything is so good. The fireability, I just have to stay in the center. You can actually close your eyes and operate with this Signature Pro without any problem.
Dr. Mohan, I have one question. Very often we keep discussing about the use of ERV lens in mild, having mild NPDR or something like that. Do you prefer doing these IONS lenses in PDR?
Yeah, IONS lenses, there's no contraindication. Okay. Even if the patient has got ERM or anything, any diabetic retinopathy or macular edema, doesn't matter, because it's just a unifocal plus lens. That's all. The advantage why IONS has penetrated, become very popular, is because the cost is not very different from the Technis monofocal lens. Okay. If you have IONS as about 40,000, 50,000, I'm very frank about it. but they're not having it very much thing, and the benefits are more than the cost. I would say that is the reason IONS has penetrated the market like anything. It's become one of the most popular lenses among all the cataract surgeons today across India, that many of them are using either IONS or a multifocal. The multifocal.
There's no doubt about that. Rajesh,
yes.
In your mind, once you're asking this question of NPDR and
yeah,
you had something in mind?
Yeah, I had this thing in mind that if any lens which does have extended range, will it have a problem? Because the standard teaching is that if there is anything in the media from the tear film to retina, then it's you should not use multifocal. That is sure that we all agree with this. Just the IONS lens is something which is in between monofocal and multifocal, and that is why there are variable reports, and there are many people who are convinced using it in mild NPDR, in mild diabetic retinopathies.
I'm using even for other cases also. I don't find any difference, and I don't any contraindication using IONS. As long as you can use monofocal lens, you can use IONS as well. That's my take on this. Lalit, I hope you will agree with me.
No, I agree because today only in the OPD I had one patient, right eye surgery was done last week, and he was unaided 6/6. So in the left eye, he also demanded same. I told him the same what you're saying, will make you 0.5 this thing so that you will be comfortable with mobile and maybe near job. So although he said, I want to see distance clearly. So I told him distance, with 0.5 will not much affect it, but you will be comfortable for most of your near work.
Yes, most of your near work. Yeah. See, please understand, the expectation of the patient is directly proportional to the cost of the surgery. Okay, if you're going to charge them 1.5 lakhs for a femto synergy or something like that, his expectation is going to go up.
Yeah.
Okay, with IONS, you don't have to charge so much. So your expectations automatically come down. So that is the mentality of all the patients. That is where I think IONS scores very well, because your expectation, you under-promise actually, but actually it over-delivers. Most patients, they're able to manage without glasses because they're able to keep it straight or the down, or they'll require 1.5 only, or 1.75, not 2.5, 2.75, like the regular monofocal lenses.
And that is the reason I think this has become number one lens today.
Yes.
So there are two questions for you. One is that for a trifocal, if it is a mature cataract, you can't see the macula at the back. Then how do you decide whether you will give a trifocal or not? And the second question is that what was the configuration of the tip that was being used? Was it phaco tip, 0, 10 degree or 30 degree?
No, it's a 15 degree tip. It's a straight tip. Okay, 15 degree. That is the advantage of the ellipse. Whereas in Ozil, you require a Kelman tip. Otherwise, the Ozil will not work. The ellipse will work with any tip.
Balance.
The ellipse will work in any tip. So that is the advantage of this regular 15 degree tip, and which is there, which I used. Okay, this patient also had focal in a mature cataract. I'm sorry, the synergy toric, which I did femto. The other eye, we go by the other eye. We go by the B scan. Sometimes we use IOL Master 700. Okay, many times we use. Always you use the IOL Master 700. Will be able to penetrate this. In fact, we are able to get an image in this IOL Master 700, able to penetrate this cataract because this uses SIPSOS OCT, SSOCT. Will get some sort of a idea of the macula, exactly what is going to happen. Right?
And plus the other eye can be examined, and then
other eye, of course. Other eye, of course, we have to do. Even otherwise, we do regularly OCT for all these patients. So, okay, the IOL Master 700 itself has got a beautiful thing because it goes through the fovea, SIPSOS OCT, and because of that, you will be able to, suppose there is a macular edema or a ERM or something like that, we'll be able to find out. So, this case, though the lens star was not giving the any values, and we used IOL Master 700, and we got the value for this, and we good idea. It's view of the macula. You'll know grossly whether something is wrong or not. Mostly from the other eye, you can find out whether the patient has got any diabetic retinopathy in the other eye. most probably that is not a good, probably this patient will also have some diabetic retinopathy in the other eye and in the mature cataract eye as well. So that is not probably a contraindication for a trifocal lens or a multifocal lens.
So I think many congratulations. Are there any other questions or comments? Otherwise, sir, we can conclude.
Wonderful job done, Sujata. Excellent surgery. Very nice.
You can also see it is all there on the Facebook and the YouTube. People are really.
Lalit, you didn't tell about my surgery.
Congratulations.
No, I joined late actually. I joined late. I'm sorry for that.
What is this, Lalit?
No, I'm really sorry. I watched every step of the surgery, therefore I could comment on that. I'm sure you must have done equally well.
No, all the 3 cases were done fantastically. Very well done.
And more importantly, the tips and the tricks that you have given while doing the surgery, also after that, I think they have been most useful.
Actually, Mohan, I had joined on YouTube initially, so Namrata speakers link now only. So therefore I could join. Otherwise, I didn't have speaker link. So therefore,
if you had told me that you're joining late, we could have postponed the surgery. Anything for you, boss.
Congratulations, Mohan and Sujata. Excellent job done.
Thank you. Thank you.
Really proud of you people.
I would like to again thank the AOS for giving this wonderful opportunity to Rajan Eye Care and thank the J&J team. They've been here and they've been working for the past 2 or 3 days to make this program a very huge success.
Can you show them?
Entire staff of Rajan Eye Care. Okay, and we are looking forward to I know it's clashing with the Lalit. I'm very sorry about it, but it is on the last day only, wherein you are having only half a day of the program. So January 8th, surgical strikes. So anyway, I'm going to be there in the midterm on 6th and 7th with you guys.
Okay.
Thank you.
Okay, thank you. Bye-bye.
Thank you.
Yeah.
Thank you, both of you.
Thank you. Bye-bye.
Sujata, Rajan Eye Care Center. I should thank Sujata first because she's done 2 surgeries. So thank you, Sujata, Mohan, Rajan Eye Care, entire team of Rajan Eye Care. And I think we've had one of the most interactive Surginars today because Mohan doesn't stop talking. So there were so many tips and tricks, which came out of that. And thank you, Dr. Lalit Verma sir, for joining. And I would like to thank Mr. Sami from Johnson & Johnson for doing this event and doing event after event, and that too so well. And of course, thanks to the audiovisual team as well as the AIOS headquarter, Mr. Kripal Rana and his team for this surgery.
Great job done. Okay.
Yes.
Very well done. Very well.
Thank you very much. And whoever wants my chopper 1.75, I would please mail to me, or you can call me up. I'll be able to send it across to them.
Sure. Thanks a lot.
Thank you.
Bye.
Including Namrata and Rajesh.
Thank you.
Lalit, are you doing cataracts? I will send it to you also.
No, I'm not doing. I have learned so much of cataract by watching only. So thank you. Bye. And congratulations to the entire team. I can see the entire team now. Should be congratulated.
The team Rajan Eye Care, which is been doing really fantastic service here.
Fantastic. Okay, bye.
Thank you.
Bye.
We'll have a photograph.